Patients with blue sclera.
Blue sclera, I'm thinking about osteogenesis imperfecta.
Osteogenesis imperfecta. What's the problem with osteogenesis imperfecta? Pathophysiology.
Imperfecta. Okay, so this is call 1, call 2.
Collagen type 1 gene
What you
defect.
say? Mm-hmm.
So how do these patients present apart from having a blue sclera? All right. So type 3 and 5 collagen defect, yes. What did you
So,
say?
Ehlers-Danlos syndrome.
This should be Ehlers-Danlos syndrome. Hyperflexibility and all of that. When you think of type 4 collagen, what defects come to mind? Give me conditions related to type 4 collagen.
It is Alport, good
Alport
pastor.
syndrome. What else?
Something with base membranes. So, good
Okay.
pastor.
Good pasture syndrome. Alport and good pasture syndrome. How do people with Alport syndrome present?
Um, it had to be something in the
Okay.
kidney and
They can't
upper.
see, can't pee, can't hear, right?
Yeah.
Can't see, can't pee, can't hear. Visual abnormality, urinary abnormality, and hearing difficulties as well. Sensorineural hearing loss, right? Alport syndrome. What's the pathophysiology of good pasture syndrome?
So good pastor syndrome. Okay, it's gonna be antibodies to
Okay.
the base brain, so it affect the not the upper, no, the lower respiratory system
Mhm.
and the renal, of course.
And the kidneys.
Mhm.
So people with good pastures have anti-glomerular basement membrane antibodies. It would affect the lower respiratory tract and the kidneys. Because of the lower respiratory tract involvement, these people are going to have what?
Um,
Hemoptysis. And because of the renal involvement, they will have hematuria. Remember, the renal involvement here is also crysenteric, right? That's the name. Crysenteric glomerulonephritis, right?
yeah,
What's the other pathology that causes or is associated with crysenteric glomerulonephritis?
is the other one that they confuse. Is the other one. I don't remember. Had to be in the lungs.
That's with the W.
Wegener.
Virginus, very good. Vaginal granulomatosis. What happens in vaginal granulomatosis?
They affect the upper and the low.
Okay, they'll affect the upper respiratory tract. So these people may have sinusitis, polyps, right? Then they affect the lower respiratory tract. They will have hematuria as well. And of course, the kidneys, right? So they will also have, did I say hematuria? Hemoptysis and hematuria. And this is the key difference between Wegener's and good pastures. Wegener's also affects the upper respiratory tract. What's the molecular finding in Wegener's? Remember that these are
Sianca.
the people with C and K positivity. Do you get that? All righty. They give you a patient with bluish line on the gingiva. Bluish line on the gingiva. What comes to mind? bluish line on the gingiva?
Um, I don't know.
Okay, these lines are also called lead lines. Well, on the gingiva, you call them specifically button lines, right? Sometimes you have them in other parts of the body, like on the bone, on the epiphysis of long bones. We can call them lead lines. Do you get it? Or button lines. Not like you have to use that term for them. But what disease will be affected or will be causing this presentation? Lead poisoning, right?
Um,
What are the two enzymes in the heme synthesis pathway that are inhibited by lead? The two enzymes
oh
in
yeah.
the heme synthesis pathway inhibited by lead.
So porphyrinogen is
What
from
did
the
you say?
porphyr. Is the sideroblastina?
Mhm. Yeah, it will cause sideroblastic anemia.
So I just have in my mind the mitochondria and the other part, but I don't remember this.
So you remember the enzyme
Porphyrinase.
ferrochelatase, right?
Yeah.
You remember ferrochelatase. What's the second enzyme?
It's
That
the
was
one in the
ALA
upper ala.
dehydratase,
Ala desintegrase. Yeah.
right? ALA
Mhm.
dehydratase. Which vitamin deficiency also caused sideroblastic anemia?
Vitamin B6.
B6. Which medication? When you think B6
Uh,
sideroblastic anemia, what's the big drug?
isoniazid.
Isoniazid. Isoniazid. You remember the mode of resistance against isoniazid?
Um, yeah.
What was
Yes,
that?
I remember. It's a mutation of CATs in Q.
Okay, so decreased CAT-G expression, right? That would be a decrease in CAT-G expression. Do you get that? All right. Patient presents with bone enlargement, bone enlargement, and arthritis.
Maybe spaghettisis.
Paget's disease. What are the stages of Paget disease?
Questions. Hmm, I know that is an imbalance between the autoclast and osteoclast,
Okay,
but
so
I
it's
don't
primarily
remember this.
an increased osteoclastic and osteoblastic activity, right?
Mm.
So you can learn them in sequence. You can remember that, first of all, there's this massive destruction of bone. So there's increased osteoclastic activity, the osteoclastic phase. We can call that phase one. And then you have the osteoblast trying to fix what is going on. So we have this sort of osteoblast coming in, but osteoclasts are still working, and that gives us a mixed phase. This mixed phase is where the osteoclasts and the osteoblasts are working at the same time, excessively, right? And then the osteoclasts eventually give way, and now we have predominant osteoblastic phase. Do you get it? And then we have the
Mm.
quiescent phase. Everything becomes quiet.
Okay.
What is increased in Paget's disease of the bone?
Calcium? No, sorry, it's not calcium. It's alkaline.
Alkaline phosphatase,
Okay,
right?
it was good.
ALP, alkaline phosphatase. How do we treat Paget's disease?
Uh, Biphosphonates.
Bisphosphonates. Give me one medication, one example.
Mm, biphosphonates. Okay.
Alendron, right? You have
Yeah.
to remember that. What is increased in
Mhm.
people with osteoporosis?
what is increased in people with osteoporosis?
Yeah.
Um, osteoporosis,
What is increased in osteoporosis?
phosphate too?
Nothing. You have to remember that. Trick question. In
Oh, okay, yeah.
osteoporosis, everything is normal, right?
Phosphate. Mhm. That's
Everything,
tricky question. Yeah.
everything is normal. All right. So they give you somebody with bounding pulses. Bounding pulses, diastolic heart murmur, head bobbing. What comes to mind?
So I was thinking about aortic stenosis.
Aortic
No, sir.
stenosis,
No, sorry. Regurgitation.
aortic regurgitation,
Mhm.
right? This is more aortic regurgitation. How do people with aortic stenosis present?
Aortic stenosis.
What's the classic presentation for aortic stenosis?
Oh, well, the classic presentation is more affected in all persons, more
Okay, so
than
70 year
65.
old.
Yeah. It's more calcification, and we're gonna have a hypertrophic of the
Hypertrophy, but we're not going to see that. The patient will not present with that, right? So 70-year-old patient with chest pain, shortness of breath, syncope. Chest pain, shortness of breath, syncope, aortic stenosis, right?
yeah.
70-year-old man, classic presentation, chest pain, shortness of breath, syncope, aortic stenosis. Aortic regurgitation is more dynamic. So bounding pulses, diastolic heart murmur, head bobbing. Because when you at first you have the contraction and then a lot of blood returns to the heart, and then on the second contraction you have this increased volume of blood pumping out, right? Producing those type of pulses. All righty. They give you a patient with butterfly, facial rash, and Raynaud phenomenon. A young female,
Less. Loops.
lupus, SLE, right? Remember on this exam, if they give you a young female with joint pain, you should always suspect SLE so that you don't miss it, right? A young female with joint pain, you want to suspect SLE. Remember that SLE is associated with what? Early complement deficiency, right? C1, C2, C3, C4, I think, as well in SLE. Okay, then we have, what do we call it? The findings in SLE. What are the presentations we have in people with SLE?
Presentation. The malar rash,
Malar rash,
insuff-
okay.
the renal failure to
Do you have a
arthritis.
mnemonic that makes you remember it?
No, I don't know. Oh well, I don't remember the name.
The mnemonic for SLE. There is one in your first aid. I think the one in your first aid is rash or pain. The one I learned was MD soap brain. So we had what? Malar rash.
Rash.
What was the D?
Mm, yes.
Discoid rash. These two are basically mostly on the face, right?
Mhm.
What's the S?
Cirrhosis.
Serositis, right? Serositis is going to be inflammation of serosal membranes, things like
Mm.
your pleura. So pleuritis, pericarditis. These are all forms of serositis. What's the O?
Oh, ulcer, oral. So,
Good. Oral and esophageal ulcers. What's A here?
right? Or something?
You can think of it as arthritis. You can think of it as anti-nuclear antibody. We can take either of the A's,
Oh,
right? Let's call one of them
no,
arthritis. Let's call the other one anti-nuclear antibody, right? What are examples of your anti-nuclear antibodies? Which one is pretty specific to
the anti-DS DNA.
anti-double-stranded DNA, right? Anti-double-stranded DNA, I think under here will come under immunologic abnormalities. So your anti-double-stranded DNA, right? There are other ones like anti-Smith and so on and so forth, but this one is pretty important. What's the P?
Photosensitivity.
Photosensitivity. What's the B?
B is
Blood, right?
ah,
And what happens with blood? Everything is low. You get that?
yeah,
Everything is low. So what do we call that? Cytopenia,
um,
thrombocytopenia, and all of that. What's the R? Renal involvement, right? The R is going to be renal involvement. What else? What type of renal involvement, what type of kidney pathology is seen in people with SLE?
is the membrane proliferative?
MPGN, right? What are we missing? Neurological symptoms, right? The the N will be neurological symptoms. So they can have seizures and what else? All of those things. What kind of heart disease, apart from pericarditis, what cardiac condition involving the valves is associated with SLE?
Hmm. I don't know.
What valvular abnormality? You remember
Mitral?
LSE? So I like to say that SLE causes LSE. What's LSE? Limansac endocarditis. Liman-Sachs endocarditis. Do you get that?
Yeah.
Liman-Sachs endocarditis. These people are going to have thrombotic accumulation on the valve, usually your aortic valve and your mitral valves, right? They have thrombotic accumulation. It's almost like watts, like how do they describe it? Verrucous, watt-like thrombi accumulating on those valves and eventually causing valvular abnormalities. Do you get that? All right. And that is SLE. How can you treat? BP,
Um,
hydroxychloroquine, right? Uh-huh. Pretty important. Which of the antibodies is in SLE is associated with
Antiphospholipid.
heart block? No, associated with heart block in newborn. So if the SLE patient is pregnant, which of the antibodies will be associated with a heart block in the unborn child?
Mm. Oh, the anti-stone.
Anti-SSA antibodies. These will be associated with heart or cardiac abnormality. You get it? The anti-SSA antibody. That is in pregnancy in a pregnant patient. Which disease is associated with anti-SSA and anti-SSB positive patients?
That is antiphospholipid.
No. Anti-SSA is also called anti-Ro and anti-La.
Oh, sorry, that is Sjogren.
Sjogren syndrome. That would be Sjogren syndrome. What do people with Sjogren syndrome present with?
Uh, dry mouth,
Dry
everything
mouth,
dry. Oh,
dry eyes, what we call keratoconjunctivitis sicca, right? What else? And dry mouth, dry eyes, and arthritis, right? Joint involvement, of course. You get it.
Oh, so I remember I have a question that was parotid atrophy. Parotid.
Yeah, it will affect the parotid gland, of course, because they are not secreting, right? So you can have atrophy. Which disease will cause parotid gland enlargement? Parotitis. What big one do you think about?
Mumps.
Mumps, right? So if you think parotitis, what else does mumps cause?
Mm, um, infertility if there's
Okay. So orchitis. And what's the last one? Pancreatitis. What did I say I
hepatitis.
should look you should look out for whenever patients have pancreatitis and sepsis? What two complications should you look for in people with pancreatitis and sepsis?
Um, oh, DIC
DIC and what?
and SAR,
ARDS,
RDS.
right? So whenever people have pancreatitis, whenever they give you a vignette and the patient has pancreatitis or sepsis, that means that they're probably going to ask you about someone with DIC, something related to DIC or ARDS. If they give you a patient with recurrent miscarriages while
So
reacting,
I think about antiphospholipid.
so this is where your antiphospholipid syndrome comes in. This is where your antiphospholipid syndrome comes in. Of course, there are other reasons why people may have recurrent miscarriages. Chromosomal abnormalities can cause them, right? On your exam, that's probably the second one. But again, it's not something I would worry about. Antiphospholipid syndrome should be the first thing you think about when they give you a patient with recurrent miscarriages or spontaneous abortions, right? Spontaneous abortion. Okay, and these people have anti-cardiolipin antibodies. Remember that? They have anti-cardiolipin antibodies as well.